I had a sleep study before the MSc in a lab where they actually stick a catheter in the nose down the throat to measure negative pressure in your airway. So it's like the most accurate gold standard for diagnosing upper airway resistance syndrome. It's called a PES. Have you heard of that before?
No, I've heard of a dice, but not a Pez.
So a DICE is a sleep study where they actually put you to sleep, and it's not a sleep study. It's a airway study where they put you to
Hmm.
sleep, and they
Hmm.
do the nasal, like a video through the nose and ENT to see where the airway is collapsing.
Mm-hmm.
So
Mm-hmm.
what I did is a regular sleep study, like an overnight sleep study in a lab. But part of that sleep study, not only hooking up the EEG monitors and the chest monitors and oxygen monitor, but they also check negative pressure in your airway through this special catheter that goes in the nose. And you kind of like swallow it. It's kind of a weird thing, but it actually checks how much harder you're working to breathe. And as you work harder to breathe, what happens in your brain? Does your brain arouse? So most sleep studies in regular labs that don't do this will only pick up on like oxygen drops. But this will look at like, kind of like young fit females or males who are not overweight, that population that's not really having oxygen dropping tend
Mm-hmm.
to get missed on sleep studies because they're not looking at those subtleties, and they might not be looking at all. They might say, oh, you had so many brain arousals in your sleep, but we don't know why. It was spontaneous. Or really, oftentimes it's actually airway. You're working hard to breathe, your adrenaline shoots up, your brain arouses, but your oxygen might not drop. So
Mm-hmm.
this is called upper airway resistance syndrome. So I had that very detailed sleep study. Well, I had it once here in San Diego without the monitor. And I had like, I don't know, tons of brain arousals all night. And they said they were spontaneous arousals. My AHI or my sleep score was 0. We don't know why. You just need cognitive behavioral therapy for insomnia. And I said, geez, I don't have insomnia. I could literally fall asleep right now if you turn out the lights. Like, I don't have insomnia. Um, it was weird. Like, I'm always moving around, going to the gym, working out, doing everything, because probably if I stop, I'll like fall asleep or something, I guess.
Mm-hmm.
So
Mm-hmm.
I was actually excited that I didn't have sleep apnea or any issues until I heard a lecture by a famous neurologist who's a sleep physician. You should have him on. His name is Dr. Gerald Simmons, and he's in Texas. And he specializes in upper airway resistance syndrome for all people like me who get missed, who just think, oh, we're moody and we have headaches.
Mm-hmm.
He can really see what's going on when you sleep, when other sleep studies might miss this. So I flew to his lab in Texas, and I did the PES sleep study. So same type of sleep study, but they put that catheter, that monitor. And he found out my AHI was actually 24. So 24 times an hour, my breathing, I was struggling to breathe at night, basically. And my RDI, or respiratory distress index, so the amount of times my brain woke up because I worked harder to breathe, was 36 times an hour. So every 2 minutes, my brain, because they, check, was waking up out of a sleep cycle. Of course, I'm going to
Mm-hmm.
have headaches. Of course, you're going to have like facial pain, clenching your jaws to like stabilize your jaw, and you're going to be tired and moody, and whatever other issues occur with that. So I got another sleep study after the MSc. I still had it in. So it'll push your tongue down, right? But I did
Sure.
another sleep study, and my score went from 24 events per hour down to 6, just with MSc,
Wow.
nothing else.
Wow.
And it was still in. So if I did another sleep study with it removed and with the myofunctional therapy hitting that hard, it probably would be way lower. So
Mm-hmm.
it went
Mm-hmm.
from abnormal to just slightly mild, just from expanding the palate.
That's incredible. What a testimony.
So I just went on and on and on about me and that.
No, that's an incredible testimony. Most of the people watching this video are considering MARPI in one form or another, and I'm sure that and like you, a lot of them have gotten false negatives from sleep studies. It's a huge problem.
It's a huge problem.
I can't tell you how many people sign up to speak with me and they tell me they've done a sleep study and it came out negative, and I'm looking at them and they're telling me they're chronically fatigued and they obviously have small jaws, and I say to them, okay, you're definitely on the spectrum somewhere.
Mhm.
You may not be past that threshold where the insurance company calls it sleep apnea and they're willing to pay for therapies for you, but it's not black and white. It's not a switch on off. But it's very interesting to learn about the plumbing behind what's causing these false negatives in sleep studies. Is there so would you recommend this? Is there any way to get this PEZ sleep study apart from with Dr. Simmons in
You know,
Texas?
there might be like less than 20 labs across the country that use the PEZ monitor. And there might be other ways to pick up on this with like a watch pat, which is not a true like sleep study in a lab where you're using sensors on the brain, but that
Mm,
can kind of assume autonomic nervous system arousal. So you can kind of see those things from that. I don't know. I know Stanford used to use a PEZ. I don't think they use that anymore. But I think the point being, when you have symptoms, and a lot of these airway issues, it's due to malocclusion, decreased space in the mouth. We're basically choking ourselves in our sleep. You can look
mm,
at a facial structure. You can do sleep questionnaires and ask questions, and we pretty much know. We're like, okay, you're
yeah.
not sleeping well. But yeah, when you get a false negative, it's really upsetting. And what most sleep labs are doing is they're not scoring these issues, brain arousals, as events if the oxygen doesn't drop a certain percent below the person's baseline. And that rule was developed in, like, I think it was in 2012. The American Academy of Sleep Medicine changed their guidelines for sleep labs and said, we want you to score events if the oxygen drops or there's a brain arousal. And it was too much work for the labs to do this. And they were worried they're going to lose their accreditation if they're not, because you actually have to really look in detail on the sleep study raw data. And someone needs to be really counting everything. And it's really a lot of work. So sleep labs kind of got upset, I guess, and rebelled. And the American Academy of Sleep Medicine have two guidelines actually for sleep study scoring. There's a Rule 1A, that's the recommended rule, that there needs to be a drop in oxygen or no drop in oxygen, but a brain arousal. And that can be counted as an event. But
Mhm,
Rule 1B is the accepted rule, not recommended, but they'll accept that rule also. And that's the Medicare rule, that there needs to be a 4% drop in oxygen to score an event as an event. So
mhm,
most labs are using Rule 1B. And they're
mhm,
ignoring the fact that a lot of us younger people who are not elderly and obese, who are not literally gasping for air all throughout the night, who might not even be snoring, are not having oxygen drops. Our brains are so hyper reactive to our ability or lack of ability to breathe easily. So as the airway kind of collapses, your brain arouses right away before your body has time for the oxygen to drop. So those are going to be the people who are, narrow jaws, retruded jaws, scalloping on the tongue, um, who are, maybe baggy eyes, venous pooling, kind of like flattened cheekbones. There's all different facial characteristics, but the daytime characteristics are going to maybe be fibromyalgia or fatigue, excessive sleepiness, or maybe they're not sleepy, they're just fatigued. You just
mhm,
feel like crap, like
mhm,
it's
mhm,
exhausted, or anxiety or depression. Because imagine if you're running a race all night in your sleep, your autonomic nervous system is dysregulated, so your fight or flight is just hyperactive. And at nighttime is when everything should calm and you should restore. And if your heart rate increasing all throughout the night, during the day, you're going to have maybe panic attacks. You're going to be stressed out, anxious. Maybe you're going to be depressed. So there's all those socio-emotional symptoms that you might feel, headaches or migraines, or headaches from either clenching the jaw or from the brain arousals all throughout the night. There's all different signs and symptoms that those people may have, and they may score fine on a sleep study because it wasn't scored with maybe the recommended rule, or the PEZ monitor will clearly pick up on that. So probably like asking Dr. Simmons what other labs he knows that uses that. There might be some in
mhm,
New York. I
mhm,
think there's around the country, there's a few. And the reason I think a lot of labs don't use that is it's just a little bit harder to do. It's more
mhm,
training for the technician. But from my personal experience, I was able to see, okay, wow, I just thought maybe my first sleep study, I just thought, okay, I'm just, I'm a person that gets headaches a lot. I'm, maybe have a lot of anxiety. It's just how I was born, until I
mhm.
realized, oh, I'm not sleeping well.